Hello everyone, my name is Maria Anastasiou, I'm a hematologist, and today I will present you an interesting paper on CAR-T cell therapy in patients with relapsing multiple myeloma. For those who are not familiar with this fascinating treatment, I will make a quick introduction. T cells are the guardians of our immune system, and they are able to eliminate cancer cells. In CAR-T cell therapy, healthy T cells are taken out from the patient's body with a process called apheresis. T cells are transferred to the lab and they are modified in order to express specific receptors in the surface. These receptors are capable of recognizing, attaching, and killing cancer cells. Modified T cells are now called CAR-T cells. It stands for Chimeric Antigen Receptor T cells. CAR-T cells are infused back to the patient's body to detect and kill cancer cells. This highly effective treatment is approved for many types of blood cancers, including multiple myeloma. Multiple myeloma is a type of blood cancer that cannot be cured. Therefore, multiple lines of treatment are used to achieve and maintain remission for as long as possible. However, the outcome worsens with every subsequent line of therapy. Moreover, resistance for traditionally used drugs such as lenalidomide has become more common, highlighting the need for different options. Ide-cel and cilta-cel are the two types of CAR-Ts approved for multiple myeloma for patients that have received 4 or more lines of previous treatments. In this study, called the CARTITUDE study, CAR-T cell therapy, the cilta-cel, was compared to the standard of care for patients with multiple myeloma that are refractory to lenalidomide in order to assess the safety and efficacy of cilta-cel. CARTITUDE-4 is a phase 3 randomized open-label study where 419 patients with multiple myeloma, having received 1, 2, or 3 previous lines of treatment, were randomized to receive either cilta-cel or physician choice standard of care. Median follow-up was 15.9 months. The primary outcome was progression-free survival, the PFS. At 12 months, PFS was almost 76% for the cilta-cel group versus 48.6% for the standard of care group. More patients in the cilta-cel group had a complete response or even better. Safety data showed that 76% of the cilta-cel group presented cytokine release syndrome, a common side effect for this type of treatment, mostly of grade 1 or 2. In conclusion, the cilta-cel was associated with a longer progression-free survival compared to the standard of care in patients with refractory to lenalidomide, multiple myeloma, having received 1 to 3 previous lines of treatment. The strong points of this study are the big sample of patients, with 81 different centers participating in the study, that the population presented well-balanced characteristics reflecting the real-world patients with myeloma, and the fact that cilta-cel was studied in an intention-to-treat population. One limitation could be the fact that at the time of the study initiation, 2 of the most powerful triplets in multiple myeloma were not approved. Therefore, they could not be included as options in the standard of care group. Whether the CAR-T cells would have performed less good when compared to those triplets remains to be defined in head-to-head comparisons. Overall, the CARTITUDE study provided with some very interesting data regarding the use of CAR-T cells at earlier stages of the disease. Current studies are looking at the CAR-T cells also in the frontline setting. Hopefully, in the near future, the right timing for infusing CAR-T cells will have been defined for myeloma patients. This is all for now. Thank you very much for listening or watching.